Good morning, everybody. So, welcome to the CPD sessions conducted by Sri. So, we are today and starting a new topic. And today, I will just remind you about the housekeeping. So, always keep your mics muted and also videos muted. And you have a question time, and also you can put the questions in chat box. So, the webinar link will be there from 9 a.m. to 9:50 a.m. to join in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to NCCPD guidelines. This is to improve and maintain the things. They're asking questions about asking questions, so you can ask the questions at the end of webinars. And if you have a question, please type it in the chat box. And please change your chat settings to all panelists and attendees so your questions can be answered. And if you have very specific questions about your subject, please email us on office313@gmail.com. So today I'm going to introduce our speaker, the Dr. M. Shazar Hameed. She's the Fellowship of Spinal Surgery, the Consultant Orthopedic Surgeon, Teaching Hospital, Badulla. And he will be talking about cervical spondylotic myelopathy. So over to you, sir.
Good morning. All right. So I'm going to talk to you about, before I share my presentation. So the topic I have chosen for today is about cervical spondylotic myelopathy. So we have all heard about cervical myelopathy, and we've also loosely used the term always cervical spondylosis. So I will teach you why we are discussing about this specific topic. And cervical spondylotic myelopathy happens to be the commonest reason for cervical myelopathy. Right. So thank you for the moderator for introducing me. So I am consultant orthopedic surgeon currently attached to Teaching Hospital, Badulla, and spinal surgery happens to be my chosen subspecialty or field of interest. So before we start, I'll just give you a classic patient's history, how on a patient we received quite recently. So I hope that will be an intro for the rest of our lecture. So this patient is a 75-year-old female who presented to us with numbness in both her hands and progressive loss of dexterity, which happens to be progressing over the last 6 months. So she had difficulty and weaknesses in performing certain activities with her hand. She feels clumsy with her hands. And also, she also complains that she was losing her balance and she's wobbly on her gait. And infrequently, she also has that tendency to fall while walking. Not so surprisingly, she doesn't have any sphincter dysfunctions. On clinical examination, she had a positive Hoffman's test and a positive Romberg's. She cannot perform a 10-second grip and release test, hyperreflexic in both her upper and lower limbs, and the plantars were upgoing. She had a non-dermatomal pattern of sensory loss. So accordingly, we had an MRI scan done, suspecting a cervical cord compression, and this happens to be her MRI sagittal image at the mid-sagittal level. So as you can see, so the spinal cord is compressed in this patient at multiple levels, which is causing the spinal cord to be indented. And also, there is what we call signal changes inside the cord. And we'll also discuss about the last term, which I have referred to as OPLS. So this is a typical history. Now, cervical myelopathy is so common, it is frequently underdiagnosed. Even if it is underdiagnosed, we have noticed that a lot of our doctors in our community do not have a proper idea where to direct. And also, we've noticed that there is a notion in the society that since these are old patients, whatever we do will be futile and they are not amenable to any big procedures. I will prove you why it is not over the course of my talk, right? So as I said, cervical spondylotic myelopathy is the most commonest cause of spinal cord dysfunction worldwide. Now, it happens to be due to narrowing of the spinal canal, which eventually leads into deterioration of the cord function. It's more prevalent among men. And according to the literature, nearly about 100% of men and about 96% of women over the age of 70 will show radiological features of myelopathy. And it happens to be very common among rheumatoid arthritis patients. Now, it's very important to dissect this term spondylosis. We all speak about spondylosis, right? So we speak about cervical spondylosis. This term encompasses a number of pathological events which happens in your spinal column. So when we speak about degeneration, the degeneration in the spine often starts at the level of the disc, the intervertebral disc. As you all know, intervertebral disc is composed of two elements. In the center, we have what we call is the nucleus pulposus. And in the surrounding, we have the tougher layer, which is called annulus fibrosus. So with time, what happens is the general water content in the disc material will diminish, which makes it much more stiffer. And also the microscopic architecture of the annulus fibrosus changes, making it much more weaker, causing the annulus pulposus to bulge across the nucleus pulposus. So eventually what happens is this will reduce the height of the disc. This unfortunately throws excessive strain onto the other joints at the back. So in simple terms, if you take any vertebra, it is connected to the other vertebra, the neighboring vertebra, by three joints. One happens to be at the front, which is the intervertebral disc, and you've got two joints at the back, which are the facet joint. So any problems with the intervertebral disc will throw an excessive force onto the two joints at the back, and they will eventually be subjected to osteoarthritis. So part of the osteoarthritis of any joint is that it becomes hypertrophy. The joints become quite massive. So there will be facet joint hypertrophy, which will cause encroachment into the canal. Also, because of this instability, you will have the ligamentum flavum, which is the connection between the two lamina, which becomes quite hypertrophied. That will also bulge into the canal. As I mentioned before, the disc itself tends to bulge inside. And because of this whole instability, one vertebra tends to be pushed either forward or backwards in comparison to the other, which we call listhesis. So all this collectively will give rise to compression or stenosis of the canal and hence compress the cord. So this is what happens in spondylosis, which is much more common than the other conditions which give rise to myelopathy, like cancer, infection, like TB, and so on and so forth. So how do they present symptoms? So we've discussed about our typical case. So most of the myelopathies, their symptoms begin in your hands. The very first symptoms happen to be that they complain of numbness in both their hands, which is non-dermatomal pattern. So it's not sort of distributed to a particular dermatome. They feel their hands are clumsy. They're unable to do fine motor activities with their hands, such as buttoning, handwriting, using a mobile phone, so on. And with the with progress of the disease, they can have instability of the gait. And we think that it's all slippery because of slipping nature of the flow, which could result in falls. But in fact, some of them do suffer from cervical myelopathy, giving rise to gait instability. And some of them do admit they've had physical falls quite a few times. They also may or may not have axial neck pain or arm pain. So arm pain is which can be in radicular in nature. When we say radicular, that means that your individual nerves are compressed in the cervical spine, giving rise to what we call cervical radiculopathy. And there's this specific phenomena in some patients, not so frequent. They present with something called Hameed symptoms, where you feel like an electric jolt, which sort of passes along the spine from top to bottom. It is at the very terminal stage that these patients would present with sphincter incontinence, the bowel or bladder incontinence. When you examine this patient, you would have some motor weakness, mostly in the hands. So the classic signs of upper motor neuron disease, such as hyperreflexia, clonus, Babinski, this may be positive. So you can evaluate gait disturbance. You can do a Romberg's test, or what we call is a timed walking test, or a walking Romberg's test, which I will discuss with you later. And there are certain provocative signs. Most of us would have heard about the Hoffman's and the inverted brachioradialis reflex. And another sign called a Hameed sign, just like the Hameed symptom which the patient presents with, you can elicit this by asking the patient to flex his neck and inquiring him whether he has the feature of electric current passage along the back or along his spine. You tend to see a lot of muscle weakness, especially with the hands. And it's very noteworthy mentioning something called a phenomena called myelopathy hands. Because as I mentioned before, mostly it begins in the upper limbs, the hands, and then progresses downwards. So most of the first symptoms and signs we will only identify in the hands. So there is a specific test called a fingerscape sign. It also be noticed. We'll discuss it along the way. The most important test for me is the inability to do a rapid grip and release test. So you can ask the patient to raise the arm upwards and do a rapid grip and sort of release of his hands for about 10 seconds. If any patient cannot perform at least about 20, so that means, or they're sluggish in performing, and suggests that these patients are having early myelopathic features. So there's been a lot of papers on which is the most sensitive sign. And what they have evaluated is a test called walking Romberg's test. So the walking Romberg's test is performed by asking a patient to walk between two standard points for an expected duration of period with eyes open initially, and then to do the same walking for the same duration with eyes closed. Any sluggishness in the nature or delay in performing this task is a positive. So that's walking Romberg. So they've identified about nearly 75% of the people, myelopathies, tend to show this sign. As you know, Hoffman's sign is the most prevalent in myelopathies. Nearly about 79 to 80% would show this sign. And collectively, if someone has Hoffman's and walking Romberg's positive, there is about 96% chance that they are a myelopath. So you already, most of you would be knowing about how to perform a Hoffman's test and to observe the reflex of the other two fingers. So what on the right-hand side of your screen, you would see this is what we call is the fingerscape sign. You would ask the patient to raise both his hands or her hands with all the fingers adducted. And myelopathies, typically you can notice mostly the little finger, also sometimes the ring finger also goes into abduction and bit of flexion. That is called the finger escape sign. This is a Hameed sign. How you elicit that? You can force the patient to gently flex the neck and ask whether he or her has a sensation of electric shock sensation, which occurs with this movement. Now, there is, in most of the conditions in orthopedics and spines, people are quite fascinated about grading this condition. So grading will help you on few things. First, it will help you to say how bad the patient's condition is and whether the patient needs any intervention. And for comparison's sake, for example, if you are to perform any form of a procedure in this patient, for example, like a surgery, you would like to evaluate whether your intervention has made any improvement in this patient or not. So worldwide, one of the most accepted grading happens to be what we call is the Newry grading. So the Newry grading has a grade from 0 to 5, 0 being where there's the symptoms or signs of root involvement with no evidence of spinal cord disease. So there is progressive worsening based on the patient's mobility. And in the last grade, you would say the patient would be either bedbound or chair-bound. Now, one criticism about this grading is that, as we discussed before, mostly myelopathy begins with hands. It is only at a very latter part that you will have gait and the lower limb involvement. So this grading, though was accepted widely before, gives a great deal of emphasis to the patient's mobility and not the hands. So this will be a bit of a problem to diagnose and sort of evaluate patients at their early stage of the disease. Currently, what is mostly accepted is this new grading system called the Modified Japanese Orthopedic Score. You don't have to remember all these, or you don't have to sit. At least knowing that this is available is a great thing. So this evaluates motor functions in your upper extremity, lower extremity, separate your sensory and bladder functions as well. Based on each, you would give them a score. And based on the score, you can also categorize them as mild myelopathy, moderate, and severe. So in my setup, when a patient does not have very obvious features of myelopathy, but you can see there is subtle features and there is evidence in radiological evidence of myelopathy, you would like to grade them. So I tend to have this in my clinic so that I can, in dubious cases, evaluate patients based on this modification scale. So how do you diagnose this patient? So, well, you can start with the basics, especially you can do a plain X-ray. Especially on a lateral X-ray, you can diagnose so many things. You can see generalized spondylosis can be evaluated with X-rays. So you can evaluate how the canal is narrowed. There's something called the Pavlov's ratio. We'll speak about it in the subsequent slide. The most efficient or the most established way of diagnosis myelopathy is MRI scan. It will not only help you to diagnose, it will also help you to evaluate the extent of the disease and how severe the condition is, and also most importantly, to rule out mimics. So somebody who's coming with a lot of elderly, middle-aged or elderly patient coming with motor symptoms in hands, you also got to make sure that they don't have any other mimics, such as especially anterior horn cell disease, which needs to be evaluated and ruled out, and so an MRI scan becomes helpful. I hope you all have heard something called a CT myelogram. It's a very cumbersome and a very difficult to perform procedure. The only advantage of having a CT myelogram is in patients who an MRI scan is contraindicated, or patients who cannot tolerate MRI scan. The unfortunate thing about CT myelogram, it will help you to diagnose any form of compressive disease, but it will not help you to exclude any other mimics, as I mentioned before. So neurophysiological studies, what are the uses of them? So we never use neurophysiological, or very rarely use neurophysiological studies to diagnose myelopathy. But if the presentation is quite atypical, in order to rule out mimics, it's very important to do neurophysiological study. And also a normal CT of the neck is very important, especially in subcontinent and Asian population, because there is a significant proportion in our population where the posterior longitudinal ligament in the canal is calcified. So ossification of posterior longitudinal ligament is common among Asians and than the Westerners. So that may change the plan of our management or what we do to the patient. So on the left-hand side, this shows an MRI finding at the level of C4, C5. It is a T2 sagittal image, which shows at 4-5 there is a bulge of the disc, which is compressing the cord, indenting the cord, and you also can see there is signal changes within the cord. And the one below shows a classic X-ray, CT in the middle, and an MRI on either side, which shows cord compression along with calcification, which you can note inside the canal anteriorly. This is classically ossification of posterior longitudinal ligament. It's very common, my dear. And I talked to you about assessing canal diameter using the X-ray. We say something called a Toggs-Pavlov's ratio. So at the level of C4, you can evaluate on a CT or an X-ray the diameter of the canal, and which should be divided by B, which is the length of the vertebral body. So anything, as I mentioned before, anything less than 0.82 is significant. So now we know uh, we've all heard about myelopathy, and we've all heard about, we know all these symptoms, and say most of you must be knowing. So what we do is very important. So this is where why I want to discuss as conundrums in managing CSA. Before you do intervene on something, you always got to know the natural history of the disease, whether it's really necessary to do something. So there have been a lot of studies about evaluating the natural history of cervical spondylotic myelopathy. So the commonest natural history, which most of us accept, is adopted by this paper by Clark and Robinson, who describes about 3/4 of the patients show gradual worsening, which occurs in a stepwise fashion. And he also said that about 20% slowly worsen and about 5% experience rapid onset. And in another paper, another couple of authors have sort of noted that there'll be long periods of non-progressive disability, which may be the rule, and a progressively deteriorating course was exception. Also, there is another author by the name Nurick. He also has shown that there will be initial phase of deterioration and followed by a static period, which may last a number of years. But as most of the papers would suggest, at least in short term, the natural history would be of something stable. Only a modest number of patients will improve, whereas significant minority will eventually deteriorate, which is very important. So worsening can happen in any way. Sometimes it may be gradual or stepwise, progressive fashion. Unfortunately, the clinical course of an individual patient is very difficult to predict. So we can't evaluate, so we can't look at a single patient, say whether he will progress, whether he will be static, or whether he will improve. So what are the factors which determine the outcome following surgery? So obviously we can see this is a degenerative process, and there is obvious cord compression, which is causing dysfunction of the cord. So you would like to physically avoid or relieve the compression of the cord quite often by performing a surgery. So who will improve? So there have been so many papers, so many studies which have evaluated so many factors which may have an effect, which may be a predictor of outcome. So they've evaluated the symptom duration, the severity at presentation, age of the patient, whether it has any relevance with the neurophysiological changes preoperatively taken, whether the patient's alignment of the cervical spine, they say either lordosis or kyphosis, whether this has an impact, or the degree of compression in the MRI. So any changes in MRI, whether these are predictors. But the only significant predictor, according to the literature, happens to be the symptom duration and severity at the time of presentation, which I have highlighted. So somebody who has had long duration of symptoms are likely to improve significantly after surgery. So are patients who are having severe myelopathy at the time of presentation. This also happens to be a negative predictor. So what are the type of surgeries you can present? So how you operate on this patient, what type of surgery you offer them will depend on the site of compression. Now, that is why we discuss about the anatomy and the pathophysiology. So you can imagine sometimes the cord may be compressed from the front, like you get a very bulging disc, or you got a big calcification mass in the posterior longitudinal ligament, or you can have elements from the back, which is compressing the cord. Like as I mentioned before, the facet joint might be quite hypertrophied, which is bulging into the canal. Or sometimes you can have the ligamentum flavum at the back, which is hypertrophied, which is bulging at the gap. I hope you remember the image I showed you in the second slide. So what you do depends on where the compression is from. Then how many levels are involved? So obviously, if you are trying to do some procedure which involves a long segment of the spinal cord, we always try to do a sort of a essential but minimalistic surgery to these patients. Remember, we have mentioned this is very common among elderly people who also have their physiologies which are diminished. So their capacity to withstand long surgery, complex surgery, might not be as for a young patient. So we have to do something minimalistic as possible. The quality of the bone is very important. Obviously, we are going to either remove bone, add excess bone, put screws, put plates. So all this, for all this, the bone quality matters. And elderly patients do have a significant proportion of them do have osteoporosis. Whether the patient's neck is kyphosed or whether it's maintaining its lordosis is very important. Whether there is concomitant instability. So how we detect instability another way is if somebody is not really in a bad myelopathic shape, you can always do a sitting cervical spine lateral X-ray in a flexed and an extended position. And if the region which you are concerned about is either slipping forward or backward significantly, in comparison with these two X-rays, that suggests that there is a degree of instability. So it's very important to do dynamic X-rays of the neck when you evaluate patients with probable cervical spondylosis. That will give you or show you the degree of instability as well. And whether there is the adjacent segments are fused or not is important. And importantly, what are the patient's wishes and expectations? So it's noteworthy giving some attention to that also. So sometimes if we have any sort of compression from the front, as I mentioned you before, we often try to operate from the front. So I hope you have heard about this term called ACDF, or we call it anterior cervical discectomy and fusion. So you can approach from the front and you choose a plane between your the trachea and the esophagus on one side and your carotid sheath on the other side. You approach to the disc and you remove all the disc off from the front, which is causing the compression of the cord, and you remove the posterior longitudinal ligament, and eventually you will have to put something between that, something like what we call as a cage made out of various elements, which will eventually give rise to fusion or help these two bones unite together and cause stability. And on some occasions, you may have a large segment of vertebral bone itself and whatever is behind it causing compression of the spinal cord, in which instance you might have to not only remove the discs adjacent, but also the vertebral body, and you may have to replace it with some form of a sort of a graft in between, either artificial or synthetic, and bridge it with a plate. So you can imagine, so this kind of a procedure will cause a lot of blood loss, and it may be a bit more significant in a patient who has diminished physiological reserves. Now, in unfortunate overseas countries, they also have a technique called disc replacement. Now, most of you would have heard about knee replacement and hip replacement. So what the previous procedures would do is they will sort of fuse the two bones. Problem of fusing two vertebral bodies is, especially in a very young individual, is now you've got a long spinal column which has mobility at every single level. So this has to be quite synchronous. So if you have one particular level in the mobile part of your spine, like the cervical spine fused, that will throw an excessive load, or it will cause an excessive tension on the levels above and below. And this may cause the adjacent level discs to rapidly degenerate or wear off. We call it adjacent level degeneration. So this becomes quite significant in somebody who's young, because they are bound to live longer, and any degeneration happening in the levels above and below will affect them in their lifetime. So somebody who is young will be amenable to performing something called a disc replacement, which is unfortunately not available at the country, which will help that segment to preserve its motion. Unfortunately, so the cost of this particular device would be at least 5 times of the cost of a tiny cage we use for the surgeries, which I mentioned before. And the FDA has given a very strict indications for on whom to perform disc replacement. So somebody who is a young patient will sort of benefit from it. And who has purely a discal pathology. They can't be having a combined pathology like, overall, like I mentioned, fasciitis problem, flaval problem, and all this. So this should be pure disc compressing the cord. And there should not be any instability. And it'll also, again, I re-emphasize, you can perform a sitting or standing neck X-ray lateral in a flexed and extended position to check whether there is instability or not. And they should have a good cervical lordosis, which means the alignment should be preserved. And the level above and below should not be fused as well. Now, what happens is if you sort of bend the rules and for financial gains, apply one of these to a patient, eventually, for the faulty cause, eventually this will cause fusion without preserving the motion. So that's fine, that's acceptable. But you have spent about 5 times more than what you should. So that also has to be borne in mind. So obviously, any surgeries of this nature will have complications. So when you're going from the front, as I mentioned before, the most important thing is degeneration of levels above and below. Dysphagia happens quite frequently. And it is very infrequent to have permanent dysphagia. It's often a very transient thing because of handling of the esophagus. So what we tend to do is most often we tend to give them some liquids on the same day and progressively introduce them next day to solids. Then you can have palsy of the C5 nerve root. You can have metal-related complications and so on and so forth. Now, if you have compression predominantly coming from the back, or if you have a very long segment from the back, or any other conditions which avoid you or prevent you to operate these patients from the front, we can also operate from the back. So we can either take off what the commonest procedure is called laminectomy, or where we go from the back and we can take off all the lamina, which causes the compression and the ligamental flavor in between. So when we do that, often we tend to put screws from the back to stabilize the spine. Because the most important thing is, what we don't recognize is when we are standing erect, there is something called the center of gravity, which from the midpoint of your cervical spine, if it drops right below, it has to fall between your 2 feet. Now, if we stoop forward, if our center of gravity pushes forward, this is counterproductive for our mobility. This may cause excessive neck pain, back pain, exhaustion, and patient may have eternal suffering. So what avoids most of this is partly what we call the structures at the back. We call it the posterior tension. And so every structure at the back, the spinous process, the laminae, the interspinous ligaments, all of them are very important. So when you rip them off without stabilizing it metalwork, so they can have problems with sort of maintaining their head still. Another procedure which is performed is called laminoplasty. This is very popular among neurosurgeons, where they can sort of rip open the lamina from one side and sort of half shelve it on the other, open it up and put a sort of a plate, thereby increasing the canal diameter. So that's called laminoplasty. So in contrast to procedures from the front, the procedures from the back, you've got to go through a very thick muscle layer. There can be a lot of bleeding, hematoma accumulation, which means it is more prone to surgical site infections than the back. In addition, you've got the hairline. It's very hard to apply dressings at the back or to stick a plaster at the back. So all of this may cause contribute to surgical site infection. There is also, mind you, that there is a risk of deterioration of neurology. And since you are fusing most of the segments from the back with screws and rods, the shortest nerve route, which happens to traverse to the arm, is the C5. Because of your fusion, there can be some traction to injury to the C5. So quite often they may present with shooting pain to the shoulder from the neck, some numbness. Very, very infrequently, they may have some weakness of arm abduction. Like any procedure, you can have risk of damaging the dura, which may result in persistent leak of cerebrospinal fluid. The problem with having leak of cerebrospinal fluid is that sort of delays your wound healing, and that can also cause risk of meningitis. Okay. Now, based on MRI findings, can we predict which patients may progress, which patients may improve with surgical outcomes? This was a very important topic which has been sort of dealt with in the literature. Now, a lot of our radiologists and radiology colleagues would sort of describe any increased signal in the cord, in the T2 range, as an evidence of myelopathy. But in fact, the literature has found no correlation between high T2 signal and the recovery rates, whether it's decrease or increase. So some have performed MRI scans after surgery to see whether there is improvement of the signal intensity. But they have recognized that improvement of the signal intensity post-surgically also does not correspond to any neurological outcome. So as we can see, although it is frequently encountered in cervical myelopathy, raised T2 intensity may have no significance in predicting the patient outcome or progression of the disease. But some important papers have noted in post-mortem studies that a low signal in T1 MRI scan images are always associated with poor outcome, because post-mortem studies have revealed this is correlated with irrecoverable cord damage, which should be taken into consideration. So although MRI is a poor predictor of who will benefit from surgery and who will not, generally, all the experts will say always a signal change, as it mentioned in the MRI scans, in the cord, whether it may be T2 or T1, always correlates with some form of damage to the cord. So a lot of people, or virtually everybody, will recommend some form of surgery if there is any signal changes, irrespective of the outcome. So when you mean about outcome, the most important thing we have to mention to patients is that when we are operating on cervical myelopathy is that the guarantee that we give them is that we are going to halt the progression of their neurological deterioration. Any outcome is going to be a bonus. So generally what is understandable is about, based on your severity at presentation, nearly about 60% of them improve gradually after the surgery. But the most important thing is that will at least help them retain whatever the neurology, mobility, and skills that they already possess without further deterioration. The other most important thing about this is, we already know the spinal cord is extremely compressed, and it is progressively going into a form of damage. And we know these patients have a high likelihood of having imbalance and falls. What happens with these patients have a fall is they can have injury to the spinal cord in vascular nature. So this may result in either a complete or an incomplete spinal cord injury. So what is the type of incomplete spinal cord injury? You all might have heard about central cord syndrome. So if they are lucky, they will have a central cord syndrome where most of the upper limb is involved. But if they are unlucky, if they have a severe sort of insult to the cord, they may even end up being quadriplegic. So this is why it's important to address people with myelopathy. I just talked to you about one more entity where you can have pre-symptomatic spondylotic cervical cord compression. So these are cervical spondylotic myelopathy with or without cord signal changes you detect in patients who have had MRI scans. Now, this often happens in patients like who are elderly patients who have a whole spine MRI scan for other reasons. Most of them tend to come with degenerative back pain and leg symptoms, radicular leg pain, or neurogenic claudication. So as we know, your lumbar spine and cervical spine are the mobile parts of the spine. So whatever happens in the lumbar spine is likely to happen in the cervical spine also. So in an elderly person, having a whole spine MRI scan is very important because we have seen so many patients who have concomitant lumbar issues and cervical issues. And in these patients, cervical issues may be asymptomatic. Now, what do we do with that? They have T2 signal changes. They have gross myelopathy changes in the cervical spine. Now, as a rule, if you have concomitant problems in both a lumbar spine and cervical spine, you always have to address the cervical spine first. The reason being, if you happen to operate this patient's lumbar spine, we tend to put them sort of in a prone position. Surgery may cause hypotension, blood loss. This anesthetic agents may cause hypertension. All these will affect the cervical spinal cord, which is very sensitive to these changes, and it may end up with cord injury. So unfortunately, so this is when we have to address a lower down another lesion, but they've tried to evaluate in patients with no symptoms but radiological evidence of cervical myelopathy on who will progress and not. So some of our literature will suggest that in patients who have concomitant arm pain, brachialgia, or radicular symptoms, it's likely to progress. They are likely to progress myelopathy. And also, if we perform electrophysiological changes, if they can predict some form of cord dysfunction, along with the MRI findings, they will also likely to progress. And in addition to the compression, they also have signal changes in MRI scan. This is another category of patients, even though pre-symptomatic now, will end up deteriorating with time. So this is a bit of a touch on the people who do not have symptoms. Finally, I said any topic about cervical myelopathy, and especially in our population, would be incomplete without talking about this entity, which is called ossification of posterior longitudinal ligament, where the ligament, the posterior longitudinal ligament, is calcified. The problem of this is, in addition to calcifying the longitudinal ligament, they also happen to sort of adhere and cause calcification of the dura. So this may cause complications in a few ways. First thing is, if you are trying to perform some form of a surgery, and if you don't address this factor, you may not completely decompress the cord, leaving a half-done job. Secondly, if you try to address it, especially from the front sometimes, you may encounter a lot of complications, like you may damage inadvertently the dura, causing leak of cerebrospinal fluid. So you may encounter this. So it's very handy, in addition to an MRI scan, to get a CT scan as well, like what I'm showing here, which shows clear evidence of calcification inside the canal. So whether you address from the front or back, it's a big topic. I would not like to sort of dwell upon it. It's more complex. So eventually, I would like to deal about, so all of you might have heard about intraoperative evaluation of the spinal cord, or we call it neuromonitoring. So this is a neurophysiological topic, which we tend to use in most of our spine surgeries. So there is an element, or rather a debate, about whether we should routinely do neuromonitoring on patients who are undergoing surgery for cervical myelopathy. There was a classic case when I was in my overseas training, a very youngish patient who was in his mid-40s, suffering from cervical myelopathy due to disc prolapse, underwent surgery from the front, and it was all straightforward. But unfortunately, the patient ended up quite quadriplegic post-operatively. Immediately, we had an MRI scan which showed cord injury to the cord. So unfortunately, these cords are extremely compressed when we are operating on them. Any form of insult, even sort of mobilizing the neck in a violent fashion, hypotension can be due to so many elements. We always try to discuss with the anesthetist to maintain a good mean arterial pressure. So any of these may cause insult to the cord. And if the surgery is extending between 1.5, 2 hours, a long-term insult to the cord, which is already compromised, may end up causing great devastating complications. So there is a debate whether we should monitor these cords or not. So it's a debate which still keeps continuing. The problem happens to be the high cost to monitor every surgery, neuromonitor every surgery. It will be of a very high cost, and also it will prolong the duration of surgery. Therefore, the evidence in the literature is still inconclusive. So in summary, cervical spondylotic myelopathy is the commonest cause of spinal cord dysfunction in the elderly, which shows progressive deterioration along lifetime. So surgical decompression is widely recommended for confirmed myelopathy. The goal of surgery is to prevent further progression, but vast majority of patients show gradual improvement. So surgical option basically depends on predominant site of the pathology. So always in our population, the presence or absence of ossified posterior longitudinal has to be evaluated for. So that concludes my talk. Any questions? How do we go for the question session?
So thank you very much, sir. So we can start with the questions. So there's one question in the chat box that they are asking, what are the non-surgical, non-pharmacological management modalities for patients with cervical spondylomyelopathy, which can be offered for the patients by primary healthcare providers? Like what are the medical management?
Right. Okay. So unfortunately, if somebody has an established myelopathy, so I'm not speaking about cervical spondylosis alone. So in my first few slides, I discussed about cervical spondylosis. So cervical spondylosis is basically degeneration of your neck vertebrae, which may cause no symptoms or symptoms. So the symptoms which are of non-neurological nature, which may be axial neck pain, you can manage medically. You may offer them neck muscle strengthening exercises. You may offer them some form of physio. You may offer them analgesics. But the moment they have evidence of neurological element compromise, then you will have to address it surgically, because the only way of relieving their cord of this pressure which is caused is. So identifying them at primary healthcare level is very important. So as I said, they may come with very subtle symptoms. At your primary healthcare level, what I would always suggest is if you think, so they don't come with individual sort of loss of sensation in this dermatoma, that dermatoma. They say they got some pins and needles, some numbness in your hand. One important thing I always do in this patient is to do what we call a grip and release test. You ask the patients, I don't know whether you can see me. Okay.
Can see you, sir.
You can see me. So you ask the patient to raise your hands and ask them to do this very fast and count to 10. So 10 seconds. Anyone with no myelopathy should be able to do 20 or more. So if they're sluggish, that is a very early stage of their myelopathy. So identifying at your primary health care of myelopathy is very important. And the most important, the other message I would have to say is that even if they're elderly, it's very important that we address it. So most of the patients we operate would be like in their 60s or 70s. Well, in orthopedics, one of the most important thing is to maintain the patient's function and mobility. If a patient's function and mobility is affected significantly, that will cause significant deterioration of his quality of life. So these patients, identifying at your level and sort of addressing them and referring to a correct place as early as possible will be very important. So if you don't have neurological compromise, you can try all the means that I told you about. But if there is evidence of neurological compromise, it's better to subject them, either get an MRI scan if it's possible at your level, even from a private sector or something, or refer them to a station who can evaluate them as early as possible. Is very important. And mind you, I've mentioned about the gradual or stepwise deterioration of this condition. So the quicker you catch them, the more neurological preservation you can give the patient. So if you if you catch them quite late, as I told you, the guarantee we give them is we are going to preserve whatever you have at that moment. So if he has very less function at the stage where we are addressing the problem, that will unfortunately not be good for the patient. I hope that answers your question.
Yes, thank you, sir. And there is another question like, for how long should we continue the asymptomatic management? Like they asked whether it's 2 weeks or how much.
Well, as I told you before, again, if you have neurological compromise, don't wait. But if you don't have any neurological symptoms or signs, there isn't anything much that we could for axial, to be honest, like most of the patients with no red flags in their neck or the back, there is no sort of specific treatment which can be given to axial back pain, axial neck pain in the absence of any neurological compromise and any pathological phenomena. So they will be either have to go to a pain therapist, pain physician, physiotherapy. This will be the combination. So unfortunately, even after evaluating for 2 weeks, so if you're speaking about axial neck pain with no myelopathy, even if you went to a specialized care, there is nothing much you'll be able to do for these patients. But if you have neurological compromise, some form of neurological symptoms, so if you have caught them up, so the earlier the better. It's better not to wait longer.
Okay, thank you, sir. So, and we have some list of questions that they were sent before the session. Like it's like
Okay.
the same topics are overlapping. So just we can summarize the things and
Sure.
yeah. So the first one is, what are the causes of cervical spondylotic myelopathy? And we discussed
so-
it, just if you just summary, yes.
Okay, so cervical myelopathy, you can speak about so many causes. So cervical myelopathy means that your cervical spinal cord is compressed and there is physiological changes of cord dysfunction. So one of the commonest cause of cervical myelopathy is cervical spondylotic myelopathy. So spondylosis is basically the degenerative procedure which happens, as I mentioned before. Other causes of cervical myelopathy can be, as I mentioned, OPLL, where your longitudinal ligament is calcified. You can have cancer, which is causing progressive compression. You can have chronic infection, which is causing. So these are all causes of cervical myelopathy. But cervical spondylotic myelopathy is a specific cause of cervical myelopathy.
Thank you, sir. So there's a bit of practical question that high waiting list to perform MRI spine. So the solution for it.
Right. So this is the thing. So in my setup, as I told you before, so we have two kind of people who come with cervical spine problems, okay, broadly. Now, we first with spine issues unfortunately, hopefully I could like all talk to you on another day on in your setup, how to identify red flags. So when we mean about red flags in spines is that which has to be addressed very fast. Degeneration is not a red flag, unfortunately, right? So, but cervical myelopathy is a very important condition which may have debilitating consequences. So when you take cervical spine, you can have either individual nerves compressed causing arm pain, which we call radiculopathy, or whole cord compressed causing myelopathy. Now, myelopathy happens to be a sort of not an emergency, but at least a semi-urgent condition. In my setup, usually if somebody comes with cervical myelopathy, I have access to MRI scan and I have colleagues who I can discuss with and at least expedite and get a scan or two done. So ideally, that should be the setup. The longer the wait, the longer the disability we are going to give rise to the patient. So in our setup, we'll have to actually evaluate the patient, and actually go out of our way to discuss with the radiological team and to at least expedite these patients. So as I told you, this is not an emergency, but it's not a totally elective as well. It has to be considered as a semi-elective condition. So it would sort of, the responsibility will be on so the individual clinician to sort of discuss with his colleagues and sort of to expedite the MRI scan.
Thank
I
you.
know it's a very complicated situation in our setup in Sri Lanka, but unfortunately that we so this is the reality.
Thank you, sir. So they ask about surgery. How common is the complications?
So when we say about the commonest complication when we do from the front is what we call is dysphagia, which is a very transient thing. It settles by the next day morning. Neurological deterioration, they give somewhere in the range of, from the front, they give somewhere in the range of 3 to 4%, back 7 to 8%, but like it's very infrequent that we see. So it's compared to other complications, these are all okay. We do, so we perform cervical myelopathy surgeries extremely commonly. So, but we don't encounter these complications frequently. So when you do surgeries from the back, the commonest things that we encounter is surgical site infection. You have to be very cautious about that. And some minor group of patients will develop arm pain, which I told, because that one particular nerve, the C5, is sort of pulled because of fusion at the back. When you do from the front, the commonest one happens to be dysphagia, which is also a transient thing. So if it's done correctly, it is also like any other surgery. So the most important thing is, like in your setup, what I would like to say is, whenever patients come to us, they are quite devastated about spine surgeries. The notion which they carry is that every spine surgery ends up with paralysis, which is quite untrue. So the rate of paralysis is extremely low, complete paralysis. So you can have other complications which are sort of general to any other surgeries, but complete paralysis is extremely rare. So it's very important to pass this message on to the public as well, because the first stage of trying to convince a patient for surgery is to, we know always the patient thinks that they are going to end up paralyzed. So that is not the case.
Thank you so very much, sir. So there is a request from several people that the sign you showed, they didn't see it. So can you please stop sharing your presentation and
Okay,
share
sure. Okay, right.
and show it again, please?
Okay. Stop share.
Yes, now we can see you clearly,
Now
sir.
you can see me, right? Okay, so can you see me?
Yes,
So grip and release test is, you ask the patient to raise their arm up, and then ask them to grip, release, grip, release, grip, release. And you count to 10 slowly, or 10 seconds. So any person with no myelopathy should be able to do more than 20. If somebody can't do that, and if they're like sluggish, that's such. So this is like, they've evaluated this in a lot of literature. They have noted that this happens to sort of occur very early in cervical myelopathy. So this is a very quick test that you can do. So the other test is the sort of the what you call is the finger escape sign. You can ask the patient to raise the hands, and you would say gradually, mostly the little finger, sometimes also the ring finger will gradually abduct and flex like that. And
the
so
Hoffman
the
sign.
Rombergs is important. Hello?
The Hoffman sign also, sir?
Yeah, so Hoffman's, you can hold on, you can stabilize the PIJ, proximal interphalangeal joint, and you ask them to, you just do this. You only flex the DIP, distal interphalangeal joint. And if they're myelopathic, you would see the fingers will flex towards each other. So that's Hoffman's test. So Hoffman's is important. Then the Rombergs, you know the Rombergs, right? And the walking Rombergs is, you ask the patient to walk between 2 points, first eyes open and then eyes closed. And you can evaluate how slow is the patient to perform that task and how sluggish is the patient to solve. So that is more important than just doing a Romberg's test.
Thank you, sir. So the last question is, are there any definitive indications where it comes to requesting MRI for axial back and neck pain?
Okay.
Since there is an unnecessary waiting list, and if the clinicians are requesting, there will be a bit of a hassle.
Okay, so when you take spines, it's important to know there's something called red flags. All right. So red flags is, so it's general spine, so up and bottom and both. So in your case, if you think something's wrong with the lower back, and if the patient is over 50, 55, don't be hesitant to request for a whole spine MRI scan. So I routinely request for a whole spine or something called a Mobi track. I hope you all have heard about the term Mobi track. Mobi track is you can do a sagittal, just a screening MRI from top to bottom, and wherever there is insult to the spinal cord or chorda equina, they do axial cuts. So that way we can minimize the cost and the duration taken for the patient. So if you have any red flags, like if you're suspecting a cancer, somebody who has had a cancer before, you are thinking that the patient has MSCC, which is metastatic spinal cord compression. So any cancer coming with back pain, that's a red flag. Somebody who has gross neurological deficiencies, weakness, just not numbness, but like gross weakness, upper motor neuron signs, this is very significant. Secondly, if you are having patients who are IV drug users, immune suppressed people, these patients having back or neck pain, you got to always suspect some kind of an infection, especially in our setup tuberculosis. TB happens to be very common in the spinal setup, so you've got to suspect. And in addition to that, all those sort of alarming symptoms and signs like loss of weight, loss of appetite, which points towards a raised ESR, this has to be borne in mind. Secondly, we all have this problem of, we deal with or discuss about or always conscious about chorda equina syndrome. So any person who having just a sciatica is not an indication to do an MRI scan urgently. So you all must be knowing sciatica. That's because you have a prolapsed disc in your back, which will compress one of the nerves and which will call leg pain, or which called near the pain distribution along the leg. So that's called basically sciatica of the distribution sciatic nerve. So this prolapsed disc, the natural history of a prolapsed disc is as such. In about 80% of people, it tends to resolve by about 3 to 4 weeks. So if it's in the course of resolution, we obviously don't have to do anything. We don't have to do an MRI scan. It's only the persistent symptoms, or mind you, if you have any evidence of chorda equina syndrome, like if you have sciatica acutely in both legs, that is very alarming, because it may be one single large disc, which is not only compressing the two nerve roots on the side, but also compressing the nerves which supply your bladder and bowel, which is significant. So anybody having any form of bladder or bowel symptoms. Now, we always think about gross incontinence. But when somebody comes with back pain, leg pain, and gross incontinence, we have missed the bus. Even though we perform surgery at that level, we can't regain the function of it. It's the subtle symptoms which you have to always ask, like whether they always feel the passage of urine, right? That's important. So if some people say, okay, that I pass urine, I can't feel it. Secondly, whether they have the urge to pass urine, very importantly. They sometimes come and tell you, I go to the washroom, I can pee, but I've actually had no sensation to pass urine. So they don't feel the bladder feeling. Secondly, whether they have the sensation to go back to pass urine. They say, I passed urine, but I feel that it's not full. It's not complete. I need to go again. And then last categories, they may have some pins and needle sensation in their buttocks in the private areas, which we call saddle anesthesia, right? Some subtle changes. So these subtle symptoms are what we have to catch, right? So when you have these kind of red flags, right? These are the patients you had to expedite to have an MRI scan. In contrast, somebody who has like long-standing sort of leg symptoms, who has like just back pain, which is not significant. So these patients would not, sometimes, keep on evaluating for patient satisfaction sake, eventually you do end up. But like we need to know who needs an MRI scan more than the other. I hope this helps you.
Thank you so much, sir, and for the very informative lecture and answering the questions and very informatively. So we thank you for the session. Like today we discussed the cervical spondylotic myelopathy under CPD session conducted by the Sri. So the consultant was Dr. M. Shazar Hameed, the consultant orthopedic surgeon, the teaching hospital Badulla, and he's an expert in spinal surgery and orthopedics. So thank you very much, sir, for your the lecture and also doing our questions and answer session. So thank you very much and have a nice day. So we posted our link for the CPD certificate in the chat box so you can fill it. And if you have any questions, please contact us. So thank you so much and have a good day.
Thank you very much for having me too. Thank you.